everyone. I want to go over the surgical cases that we have, and I pulled up case 23 just to use an example. Now remember, as we're looking at these older cases, and if you use an encoder to put the current or close to a current admit date and discharge date, do not use 1983 because you will have old codes and specifically ICD-9 CM codes, which are no longer valid and have not been since 2015, right? So for this one, we will use, January 22nd to January 24th of 2022, for example, as our dates. So we always start by reading the discharge summary. So let's go ahead and do that. With inpatient accounts, the discharge summary, remember, gives us an overview of everything that happened to the patient during this day. So our admit diagnosis is high fever with right cervical lymphadenitis. Discharge is the same, and now the lymphadenitis is better. Positive beta hemolytic streptococcal pharyngitis and iron deficiency anemia. So our summary is: patient is a 17-month-old admitted to the hospital after non-responsive to outpatient management of high fevers, high white count, and the sudden development of severe swelling at the side of the neck. Examination revealed and confirmed right cervical lymphadenitis. So our patient was admitted and started an IV hydration due to her poor oral intake for 24 hours before she was admitted. So she was placed on D5.5 normal saline at 60 cc's an hour and 500,000 units of aqueous PIN-G. The sodium was given every 4 hours by IV. Tylenol and aspirin were alternated to control her temp. And the patient's IV after 4 to 6 hours infiltrated, although patient was more adequately hydrated, and switched to intramuscular penicillin injections every 4 hours. On day 2, her injections were changed to every 6 hours and then discontinued that day later to an oral dose and QID daily, which is 4 times daily. She was discharged on penicillin, vitamin K to 5 cc's 3 times a day, and was prescribed Dimetapp elixir for congestion with the onset of mild rhinitis. The mother had been using prophylactic ganstrinin for the prevention of ear infections and will reinstitute twice a day dosage at home, and the patient will be seen in the week for follow-up. So the labs, the physician goes over the labs, and then the patient was also provided an iron supplementation, and they're going to recheck her hemoglobin in 1 to 2 weeks. So now let's look at the next report. So chief complaint in HPI. Our 17-month-old female presented to the ER after a 4-day history of high fevers with non-specific symptoms up until the time of admission, with documented pharyngitis, which grew out 2 beta strep, positive 2 beta strep, on culturing, which was done on 2/20. The child has been seen in the ER for 2 days prior to admission. The patient on initial, let me move this screen a little, make sure you guys can see that. The patient on initial evaluation 2 days ago was felt to have pharyngitis with possible early otitis and was treated with culture of the nasal pharynx and posterior pharynx, and reports were pending. Temp was controlled with aspirin and Tylenol, and the child's condition worsened on the 21st, at which time they started antibiotics with amoxicillin. Due to the increasing severity of the symptoms, she was reevaluated, and there was no noted cervical lymphadenopathy, only a slight amount on the right, but there was some question of nuchal rigidity, and a spinal tap was performed, which was clear, and cultures are still pending, but India Inc. was negative. The patient continued to worsen through the 21st, at which time evaluation was reinstituted, and there was a noted documented cervical lymphadenitis on the right, and the patient was admitted for IV antibiotics. So the past medical history of our little gal is multiple problems since birth with recurrent otitis. Finally, she had some tubes put in, the myringotomy tubes, when she was 1. Then the child still had recurrent ear problems, but it's been less severe and intense and is doing well, growing and developing appropriately, immunizations up to date, no known allergies, mother and father are good, no medical abnormalities or illnesses. Now, I won't go through all the physical exam. You guys can read through that. And then the plan was to admit our patient, start IV antibiotic and IV hydration. So then here's the handwritten notes. Again, you can scan through those. Admission progress note, diagnosis, again, that's cervical lymphadenitis. Doctor's note, this is the discharge order, discharging today with the penicillin. Discharging the IV on day 2. Doing a CBC day 3. So you can read through all of these. It just outlines everything in the discharge summary. The consent, again, you just scan over that. We can't code off the labs, right? You just want to look at those. Notice if there's anything the physician didn't document or didn't mention that you would query or ask the physician about. Graphics, you just scan over. Med records from the nurses, you just scan over. We can use those if we question if something was treated. You can always come here and look to see if something was treated and then query the physician if needed. We just scan over those instructions and the nursing documentation. This is the ER information, which becomes part of the inpatient account. So you just want to scan over that. But the discharge summary covered what happened and the H&P, and then the clothing and valuable sheets. Okay, so pretty straightforward. One thing I want to point out with this case is even though it's designated as a surgical case, the patient really only had IVs, which are considered routine, and ancillary services or procedures. We're not coding medical or surgical codes for those, so we are not assigning those. The charge master hard codes those. The coders do not. And the other thing I wanted to point out is right here in the H&P, it says a spinal tap was performed, which was clear, and cultures are pending. But this spinal tap was performed on 2/20. So that was performed prior to admission, prior to even coming into the hospital, right? So we cannot code something that was not done during the stay. So we're not coding that spinal tap either. So there is not a procedure to code with this surgical visit, even though it's called a surgical visit, it's just all medical codes. So what we are coding is the cervical lymphadenitis, streptococcus pharyngitis, and the iron deficiency anemia, because those are all the things that were treated. So let's bring up 3M. Okay, so 3M. Our patient was 17 months, so we're going to put 1 year. And then we had the dates of the 21st to the 23rd, I believe. So we're using the same dates, just a different year. And DRG finder, right? Remember, anytime you're coding an inpatient, you want the DRG finder. We're going to hit continue. The patient went home. So admit diagnosis was lymphadenitis. And let me see if I can make this bigger so you guys can see all the choices. Okay, I don't know what I accidentally hit when I was trying to do that. Okay, all the choices. So I picked unspecified because the physician did not document if it was acute, chronic, what type. We're going to hit continue on the right. And then now we're at principal diagnosis. So again, many times those are the same, right? The admitting is the same as the principal. And remember, the admitting is just a placeholder inside of 3M. We're not reporting that when you report your codes to me. So let's go through this again and do lymphadenitis. Lymphadenitis. Okay, so I'm going to pick number 1. And then down here, unspecified, because we don't know if it was acute, chronic, infective, septic. None of that is documented other than cervical, which is just the location, right? So we're going to hit N. Now I'm going to hit continue. And I'm going to add my next diagnosis, which is the Streptococcus Pharyngitis. Let's do pharyngitis. So pharyngitis, and then it was streptococcal. So I'm going to hit 9. And they did not mention do not wish to code. Do not wish to code. And then we're going to add the anemia. And it was iron deficiency, so I'm going to pick A, spell other. Iron deficiency. We don't know what caused it. There was no discussion about that, so we're going to hit 7. And again, nothing about a blood or immune disease, so we're going to hit 1, do not code. No transfusion, so we're going to hit 1, no procedures. And then we're going to hit continue. So we have our 3 codes of I88.9, J02.0, and D50.9. And then we are going to report the DRG up here at the top, remember, is 816.